Siri Hustvedt was 48 years old when she stood up to speak at her father's funeral. As she started to speak in a string voice without tears, she began to shudder violently from the neck down. Hustvedt said, "My arms flapped, my knees knocked. I shook as if I were having a seizure." Weirdly, however, she said, "My voice wasn't affected. It didn't change at all." Remarkably, she said that when the speech ended, the shaking stopped. Writing in her illness memoir titled "The Shaking Woman, or A History of My Nerves," Hustvedt contemplated that it appeared that some unknown forces had suddenly taken over my body and decided I needed a good, sustained jolting. Although she was treated for panic attacks with lorazepam, she went on to experience similar symptoms, almost all triggered by attempts at public speaking. She said the story always played out the same way. If she kept talking, the shudder may subside, and she got so used to it that what had once taken me by surprise became familiar, but that at any moment the unruly saboteur inside me might appear and disrupt the proceedings. She was then treated with propranolol, which relieved her visible shaking, but she said she felt the quiver internally throughout the event, the electric buzz running up and down her limbs. It was like shaking without shaking. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. In this episode, we will be exploring functional neurological disorders. Siri Hustvedt's efforts to understand why she started shaking inexplicably led her to explore this poorly understood domain of neurology that included previously related concepts of hysteria, conversion, and dissociation. These phenomena today come under the umbrella of functional neurological disorder, a term that is preferred to psychogenic neurological disorders. FND defines neurological disorders which do not arise from a structural or organic dysfunction of the brain or at other parts of the nervous system, and it has a very long history of association with war. For example, Siri Hustvedt noted that inexplicable paralysis, seizures, blindness, mutism, aphasia, and deafness have long been documented among soldiers who, until recently, were all men. Indeed, she stressed that the largest number of reported cases was during and after the First World War, when shell shock victims were legion. She maintained that hysteria and war go together, arguing that soldier's heart, shell shock, battle fatigue, war neurosis, and Kriegsnervose are all variants on the theme of psychic trauma due to the horror of battle. However, it is hysteria that has come to symbolize FND's neurological past. And the neurologist who is best associated with hysteria is no less than Jean-Martin Charcot, the acknowledged father of modern neurology, who devoted a lot of the latter part of his career studying this phenomenon. In her scholarly book on hysteria titled Medical Muses, Asti Hustvedt, Siri's sister, provided a detailed account of the three hysterics on who Charcot's fame rested. Muses who, she said, suffered countless indignities as patients in Charcot's hysteria ward. She said, before rapt audiences, Charcot's patients were ordered to enact degrading and fascinating scenarios. The women were also repeatedly hypnotized to perform erotically charged scenarios, ones that reveal more about the physician's fantasies than the patient's illness. But despite this negative experience, Asti Hustvedt insisted that, unlike hysterical patients today, their suffering was never dismissed as not real. The most famous of the medical muses who Charcot studied was undoubtedly Blanche Whitman. Hustvedt wrote that Whitman was admitted to the non-insane epileptic ward of the Pitié-Salpêtrière Hospital in Paris on the 6th of May 1877. Whitman, she wrote, was just 18 years old, but in her short life she had witnessed the deaths of 5 siblings and of her mother. She had also watched her father go insane and be committed to the notorious St. Anne's. Whitman's social background, also significant, is reflected by her working as a washerwoman and a ward girl, among the lowest paying and disparate jobs in the city at the time. Worse still, Whitman had had sexual relationships with at least 4 different men, and in one case with a man old enough to be her father who had forced himself on her. Siri Hustvedt explained that Whitman was sexually active in a world that looked upon sexually active unmarried women as perverse and damaged. Another of Charcot's muses was Louis Augustin Gleizes, who Hustvedt said over time has become Charcot's most celebrated hysteric because she became the most photographed hysteric on Charcot's ward. Before an attack, Siri Hustvedt said Augustine experienced an aura that began with psychic disturbances and ended with somatic sensations. And as her attack approached, Augustine felt intense pain in her right ovary that radiated down her leg, and she also experienced a suffocating sensation that was followed by ringing in her ears, pressure in her eyes, violent heart palpitations, and the sensation of a hammer pounding in her temples. And just before she lost consciousness, her vision will grow foggy, her head will turn to the right, and she will feel her hands painfully clenched. Augustine then advanced into the next or epileptoid phase of her attack, which consisted of tonic and clonic seizures and repeatedly sitting up and slamming herself back down again on her bed. She may or may not regain consciousness between seizures, and she may also manifest incomplete attacks during which she skipped one of the phases. She also executed passionate poses which included amorous supplication, ecstasy, eroticism, mockery, menace, and delirium. Siri Hustvedt concluded that Augustine was not only the most photogenic model, but she was also the most gifted. To support the functional nature of their illness, Siri Hustvedt pointed out that Blanche Whitman never experienced another convulsion, paralysis, or delirium following the death of Charcot, whose disciples also rejected his ideas after his death. While she referred to Charcot's work on hysteria as flawed, Siri Hustvedt, however, insisted that his work should not be dismissed as a medical mistake. For example, she pointed out that Charcot broke away from his predecessors who had located the disease in the female reproductive system. Charcot had moved it rightly into the nervous system. And by acknowledging hysterical authenticity, she argued that Charcot articulated a new paradigm of illness that superseded the tenacious mind-body model that we are still muddling about in. Hustvedt also said that while Charcot never found a lesion for hysteria, he always insisted that hysteria was a neurological disease. In a further attempt to absolve Charcot, she wrote that toward the end of his career, he began to inch away from his previous insistence that hysteria was a disease caused by an organic lesion and moved toward a more psychological explanation. She said he began to consider the possibility that ideas, not anatomical pathology, might be a cause of hysterical symptoms. Hustvedt therefore advocated that it is time to pick up where Charcot left off and to exonerate hysteria. And a contemporary neurologist who seems to have picked the baton is Suzanne O'Sullivan. Writing in her book titled It's All in Your Head, Sullivan defined functional neurological disorders as disorders of the imagination restricted only by the limits of the imagination. Acknowledging that FND may well be an illness of the mind, she nevertheless argued that there must be something happening physiologically in the brain to produce this ability. Indeed, O'Sullivan cited evidence of changes in the functional MRI scans of people with FND, which she said will force neurologists to redefine what we mean by functional and organic neurological diseases. O'Sullivan's approach, therefore, promises to breach the gap that has kept organic and functional disorders apart. We can now go back to the shaking episodes of Siri Hustvedt. She recalled a possible onset in childhood when she said she felt as if some superior power picked me up and tossed me about as if I were a doll. After this, she said she suddenly felt my left arm jerk upward and slam me backward into the wall. She then felt euphoric and filled with supernatural joy. Lasting just a few seconds, she thought this was a genuine seizure and her subsequent shaking episodes being functional. She might well be right, but it is difficult to be certain. What is clear, however, is that functional seizures have a variety of presentations which include swooning, pelvic thrusting, side-to-side body or head movements, non-synchronous movements, flexion and extension, abduction and adduction, and rotation, any movement you can think about. They may also present as panic attacks with excessive breathing, as palpitations, sweating, shortness of breath, a choking feeling, chest discomfort, dizziness, and unsteadiness. Derealization and depersonalization are also typical symptoms. Although functional seizures are a collection of disparate oddities, they nevertheless have recognized patterns. These patterns help to distinguish them from organic seizures. For example, the onset tends to be gradual with a waxing and waning course. They are also usually prolonged, lasting more than the usual 2 to 5 minutes of organic seizures. Injury avoidance is also characteristic, as is memory recall. The diversity of functional seizures is excellently captured by Greg Rawlings and their colleagues in their book titled FND Stories. There, they documented several illustrative examples of functional seizures. A typical example was an 18-year-old woman who, before the onset of her symptoms, said she had been a very active, successful student, but lost all of that in a couple of days. She wrote that, "I began to have 15 to 20 seizures a day, sometimes lasting hours. And for these, she was taken to 5 different emergency departments 15 different times." A characteristic episode she narrated started when she was having dinner and she suddenly felt sick. She said, "Everything was spinning and it was hard to catch my breath." She said she barely managed to say she needed to lie down before she fell into a seemingly comatose state in which she was completely aware of her surroundings. She added that by the time my parents had called 911, I had begun to seize, my body thrashing and barely breathing. Interestingly, her episodes were associated with paralysis, which could last as long as 14 hours at a time, during which she is unable to move, speak, or swallow. Understandably, therefore, making a diagnosis of functional seizures is a challenging task for neurologists. The first difficulty, of course, is distinguishing them from organic seizures, a gauntlet that is as old as neurology itself. For example, Charcot himself, according to Siri Hustvedt, struggled to distinguish epileptic seizures from hysteroepilepsy. Amongst the key distinguishing features from organic seizures are that organic seizures are synchronous, usually with no pelvic thrusting or side-to-side head or body movements. Furthermore, unlike functional seizures, the eyes are usually open during organic seizures, and biting of the tongue tends to involve the side rather than the tip. Also strongly suggestive of organic seizures are a non-fluctuating course, stertorous breathing, post-event confusion, and amnesia for the episodes. Regarding the risk factors for functional seizures, Hustvedt rightly pointed out that people who suffer from epilepsy are far more likely to have hysterical seizures than people who do not have the disease. Other risk factors include childhood traumatic events, a previous psychiatric history, a maladaptive personality, and a history of previous medically unexplained symptoms. Of course, Siri Hustvedt may not have had functional seizures at all. Rather, and perhaps more likely, was that she had functional tremors, one of several functional movement disorders out there. Functional tremors account for more than 50% of functional movement disorders. It has a mean onset age of about 50 years, which is younger than the age at which essential tremor, the more common form of tremor, presents. Also typical of functional tremors is that there is usually a precipitating event such as work-related accidents. Although they may spontaneously remit, they persist in up to 90% of cases. Functional tremors are usually absent in the fingers, tongue, and face, and they can worsen when being paid attention. Neurologists apply various clinical tests to distinguish functional from organic tremors, and these include distractibility, suggestibility, the entrainment test, and the co-activation test. The latter two only for neurologists. The progression of functional movement disorders is portrayed by the case of a 44-year-old woman narrated by Rawlings and colleagues. Her abnormal movements started as she was in bed preparing to go to sleep. They began as small movements, hardly noticeable, but then increased as time went on to manifest as daytime spasms, right hand tremor, shoulder dragging, forward movement of the torso, and startle to noise. The movements were also suggestible, as she said her neurologist once asked her to put on a somewhat surreal show. She said, "Luckily, like a circus elephant, I performed on cue and they witnessed the jerky back and arm movements." She regretted that it took a long time for her to be diagnosed, unfortunately a typical scenario for FND. And she added that if I had been told from the offset what was wrong, then I doubt it would have gotten so bad. She's very correct here because the outcome of FND is poorer the longer the symptoms drag on without a diagnosis. Beyond seizures and tremors, almost any neurological disorder has a functional correlate, from Parkinsonism, dystonia, and myoclonus to amnesia, cognitive disorder, and gait difficulties. The management of FND has become very much refined since Charcot's days of hysteria. After establishing a diagnosis, communicating the diagnosis is perhaps the most important step in managing the problem. The principles around this include telling the patient what they have before saying what they do not have, and stressing that the symptoms are genuine. It also includes providing an explanatory model for FND. The importance of effectively relaying the diagnosis of FND was stressed by Jocelyn Bystrom in her memoir titled Finding Hope. Bystrom had presented in her 40s with multiple seizures which escalated in frequency and severity the following year. A typical episode begins with shallow breathing and head swaying. She is aware as her limbs thrashed and her head jerked back and forth, and her eyelids are usually shut during these events. She said the body jerks arrived without warning and originated from my right lower back, and they occurred whenever I stood unsupported. An episode could go on for more than 20 minutes. Before she was diagnosed with FND, she had been given such labels as generalized anxiety. She had also been treated for various types of myoclonus before she had a video EEG which confirmed the diagnosis to be FND. This was diagnosis by elimination. She wrote that the first two neurologists she saw insinuated that there was no physical evidence underlying the symptoms she had described, and they implied that her physical symptoms were all in her head. She said, "I didn't want anyone to experience the immensity of despair that seized me each time a medical practitioner implied it's all in her head." A thoughtless remark that she said wounded her soul. It was later that she said a more compassionate neurologist relayed the diagnosis to her with kindness and respect. She added that so easily the message could have been articulated compassionately by saying the symptoms are real and that there is treatment and hope for recovery. These indeed are the fundamental basis of managing people with FND. But even when the diagnosis of FND is communicated effectively, O'Sullivan made the point that anger is a common response and it is always flagrant. This emotional response, she suggested, is driven by the denial of the diagnosis that many people with psychosomatic illness display. The main reason she advanced for this was the fear of patients that they are relinquishing their grip on physical disease and with it losing all validation of their suffering. Another factor that mitigates against the acceptance of the diagnosis of FND that O'Sullivan highlighted is that doctors themselves still struggle to provide a coherent explanation for psychosomatic illness. Expanding on this theme in his book titled Medically Unexplained Symptoms, A Brain-Centered Approach, Robert Balow wrote that part of the problem is that doctors are not trained to deal with common everyday symptoms, and that doctors are understandably reluctant to make a diagnosis of psychosomatic illness. He added that the process of ordering sophisticated tests and finding non-specific incidental abnormalities can reinforce the patient's fear of a serious underlying medical problem. After communicating the diagnosis, it is important to emphasize the potential of recovery from FND, as we have already seen. And the helpful interventions in this regard include cognitive behavior therapy, psychodynamic interpersonal therapy, hypnosis, biofeedback, transcranial magnetic stimulation, as well as antidepressants for emotional dysregulation. All these clearly show the significant role that psychiatrists have in the management of FND. The value of treatment is highlighted by the case reported by Greg Rawlings and colleagues, who was referred to a psychologist who, the patient said, helped me examine the root cause of my seizures and how to cope with my severe anxiety and perfectionism. She also described how the psychologist helped her to unpack her deeply complicated medical trauma from years of living with chronic illness, saying that most of all, she told me the symptoms were not my fault, and if I worked at them, I could get better. In his recommendations to patients with FND in his book titled Living Well with FND, Paul Dennant said, "It is important to find a healthcare professional who is knowledgeable, compassionate, and willing to listen to your individual needs and concerns." He further advised seeking healthcare professionals who take a multidisciplinary approach to FND management, an approach which he said may involve collaborating with other specialists such as psychologists, physical therapists, occupational therapists, or rehabilitation specialists. Dennett also advocated the value of support groups and online communities, which he said provide an opportunity to connect with others who understand what you are going through. He explained that sharing experiences, symptoms, challenges, and successes with individuals who can relate can offer a sense of validation, reduce feelings of isolation, and foster a sense of belonging. Thank you very much for listening to or watching this podcast in which we started an exploration of functional neurological disorders. If you found the podcast enlightening and helpful, why not click on the like button and subscribe to the YouTube, iTunes, or Spotify channels. And to explore neurology further, why not try my book called Surfing the Brain? And for the harder sides of neurology, you may want to check my online database called Neuro Checklist. Until the next episode of the podcast, thank you very much for your time.